Thank you. Good evening, everybody. Today it's special because after a long time we have got Professor Athul Wells and Murli Mohan sir is also on time for a change this time. So we are we are going to start exactly at 5 p.m. And we have 4 cases, and Dr. Rajan and Dr. Alpa wanted to discuss their follow-up cases, which we will definitely do. Today our radiology support is by Dr. Aparna, and thank you so much for helping us out for this. And Dr. Ritu will join us shortly for one pathology slide, which my case has got. And Mithun, it's always so pleasant to have you here. So we will move on to first case, which is by Dr. Suresh. Suresh, you're there, right? I'll share the screen and you talk. Okay.
Yeah. I'm here, Ashmita. Yeah.
Sure, sure. I believe this is your case. Just see, right?
Yeah.
Yeah.
That's it.
So,
Yeah.
yeah. Just go ahead. All yours.
So yeah. So thanks for the opportunity. This is 44 years. Can we move the slide,
Sure,
please?
sure, sure. I'm sorry. Yeah.
Yeah. 44 years old lady. She's a school teacher from Chennai. She came with a history of breathlessness on exertion for the past 2 years, and her dyspnea grading was MMRC 1, and this was increased for the past 1 week. And she also had a occasional history of cough, and she also gave history of some oral ulcers off and on. And she says she has been exposed to chalk powder. She, being a teacher, so many of the schools, even now, they don't have the DigiBoard. So she has been exposed to that, and ever since she joined teaching profession, maybe some 10 to 15 years. And she had a COVID-like illness in 2022. She was not tested at that time, and there was no history of exposure to bird antigens or any other medications. So her father died of ILD in 2022. So we don't have much of records about it. So he was diagnosed to have ILD, and he was told to have some bird-related ILD by the treating physicians. He was diagnosed in 2019, and however, there was no exposure to birds for him, and that's one family history. And on examination, this lady was thin built, and her BMI was 20. She had an unusually long neck, and she also had scleroderma like faces, and but there was no skin sclerosis. Her vitals were normal, and respiratory system examination was also normal. And this is one picture I could take. So she had a long neck, and there was a retrosternal, there was a suprasternal notch also I could see. Yeah. So her chest X-ray showed an nodular pattern, both the lower zones, and her serological markers were negative by and large. And the PFT, the spirometry showed a low FEC, suggestive of a restrictive pattern, and DLCO as well as her DLCO adjusted for alveolar ventilation when reduced. Um, so her TLC was also reduced, and there was an increase in residual volume, the ratio of residual volume to TLC, suggestive of some gas trapping. So some unusual CT findings I could see was suprasternal notch. So I think the
Yeah, Aparna will give opinion and then you can say, Suresh.
yeah, please.
Yeah,
Good evening. I'll just share my screen.
sure.
Are you able to see the city?
Yes, we are.
Yes, please.
Yeah. So these are the lung window images. And here we are seeing some kind of subpleural reticulations in the upper lobes. And as we progress down to the lower lobes, it is increasing the same subpleural reticulations. Minimal ground glass is also there as we go down. Again, there's more ground glass and reticulations and minimal traction bronchiectasis, not much, no honeycombing. So just a minimal traction bronchiectasis and reticulations for the fibrosis. And the esophagus is definitely dilated. Main pulmonary artery is not dilated. Sorry, 1 second. Mm. I'm sorry, I don't know why it's failing to load. Okay. I'm so sorry. Oh, for some reason, it's not loading. Anyway, so the main pulmonary artery was not dilated. Yeah, I agree. The anteroposterior dimension of the chest looks a little reduced, what sir was
Yeah.
telling. But yeah, the suprasternal notch, because sir just started telling it, I'm not sure how significant that is, whether it's just the positional thing. But other than that, there is definitely an ILD, I think, and pattern wise, I think it's more like an NSIP pattern. And because esophagus is dilated, plus all the clinical data, like you said, the scleroderma, like skin, etc., definitely like some CTD related ILD and young patient and everything together.
Sure.
I'll stop sharing.
Yeah. Yeah, Suresh.
Yeah, so these were the unusual findings other than whatever Dr. Aparna was telling. There was a dilated lower end of the esophagus. Are we seeing scleroderma? It's a lung predominant, CTD that's going to present later. Or my concern is whether these body habitus, whatever she's showing, is probably due to IPPFE, which is going to have onset later. So because she had a history of father having ILD and he died of ILD also. So my questions, so would a lung biopsy be appropriate at this stage? And if so, the biopsy would be safe for her. That's what I want to know, because if there is a pleural involvement without, radiological imaging showing the pleural involvement, if there is some kind of a pleural scarring, then she could land up in a persistent, air leak. So whether TBLB versus cryo or surgical lung biopsy would be better for her, would be safe for her, or should we do a genetic profiling before the biopsy? So these are the questions that I have.
Yeah. So we'll go with sir. What do you say, Murli sir and Rajan sir?
I'm not
Yeah.
sure.
Autoimmune workup being done?
Sorry?
Autoimmune workup being done?
Yeah,
Anuj?
autoimmune work. By and large, ANA is negative, RA factor is negative, and CRP, ESR, everything is acute phase reactants. It's not elevated. So
Anti-topomerase and scleroderma workup? Or?
no, I didn't go further because ANA was negative.
Okay.
I would like Mithun to say something, Mithun.
Yes.
Yeah.
Here, if ANA is negative, it is no point in going for a ANA profiling if you are suspecting scleroderma. Because most of the time, if SCL70 or anti-centromere is positive, ANA will be also positive. And if ANA is negative, 99% of the cases, scleroderma, ANA will be positive. But 1% you can get ANA negative scleroderma. Scleroderma-like facies alone, we cannot make a diagnosis. If you have other skin tightening or
No.
any pigmentation, salt and pepper pigmentation,
Yeah,
anything
she didn't
is
have
there,
any of the. No, she didn't have any of the skin sclerosis in the face or anything. It's just the appearance.
Then I think a genetic thing also you should consider. A long neck is not usual with scleroderma. But is any loss in fat can cause appearance like a long faces, long neck, and facial appearance like if loss of fat also will cause that is scleroderma like facies. Therefore, that is not equivalent to scleroderma. That's what I feel.
Okay. Can
Yes.
I make a
Yes.
comment or two at this stage? So you're starting with a woman of her age with, I agree, a CT that does beautifully for NSIP. Now, in our large scleroderma series, and I'm talking about 500 cases, about 10% have negative ANA, but about Right. Am I still audible?
Yes, now.
About 10% will have negative ANA and will have positivity on an extractable nuclear antigen screen. Just to clear up, I could see, I thought, the beginnings of PPFE on the scan in the upper zones. There was a little bit of pleural signal, and if you go back to the scan, you don't have to, but I was fairly convinced. And an element of PFE is not uncommon in CTD-ILD. I found it interesting that you had a couple of ancillary signs for PPFE, but I wouldn't say PPFE is actually a disease in this case. So I come at this saying that it is far more likely than not that this is CTD-ILD. But in one of those cases where you can struggle to nail it serologically, but I would most certainly go for a full ENA screen despite the negative ANA. And that is based on very large cohorts and knowledge of the autoantibody profiles. Now, you may be about to tell me that in India, you don't have this phenomenon of negative ANA and positivity of ENA. And in that case, I'll happily eat my words and find them very palatable. But I must say that I would be inclined to pursue the ENA screen. The ulcers might be to do with a Sjögren's serology, the mouth ulcers. And I think there's enough here. You've got scleroderma facies, you've got age, you've got gender, you've got NSIP. And I would say that at this stage, the likelihood that this is a form of CTD-ILD is in the 70 to 90% range. You have to ask yourself what else this might be. The answer might be idiopathic NSIP, but I think it's 2 to 1 likely, at least, that you will unearth a form of CTD. And the great thing about a positive serology, if you do it in more detail, I don't know why you'd do a biopsy at that point, because you will find there's NSIP here. This will not be a UIP biopsy. The history is what it is, the duration that it is. And finally, I would just observe, it might be that she didn't complete her FVC, but the RV over TLC is completed. So there may be a little airways involvement here, and in that case, you're dealing with multi-compartment disease. Now, I'd be the first to say that I haven't definitely diagnosed CTD-ILD, but you're weighing up age, gender, CT features. Idiopathic NSIP commonly evolves to CTD NSIP anyway. And then you've got your clinical clues on top of that, plus a whiff of PPFE, which would fit with CTD, but is not something I tend to see with idiopathic NSIP. So I would say the first step is a full ENA screen. I do acknowledge that it's more likely than not that it will be negative, but even if it is, I would still entertain a form of CTD NSIP and would be watching for further features to emerge. Do you do a biopsy if the ENA screen is negative? You have to ask, what is the biopsy going to tell you? And is it actually plausible you would get anything other than a histologic pattern of NSIP, in this case, given the age, gender, and scleroderma facies? It's that sort of discussion where I would expect the patient on balance to decline a biopsy, and any biopsy done here has to be with the participation of the patient. Genetic testing, I don't see anything in this case that is highlighting the likelihood of a genetic abnormality apart from the age of the patient. And I think it's all down to what your personal diagnostic algorithm is and whether you would unleash genetic testing at this stage. We would not, I think, but that is in part because of the confidence there's NSIP, which is not a big feature in genetic-associated disease, and the likelihood that it's a CTD NSIP, but I'm happy to be outvoted on that one.
I think Athol, the father died of ILD. That was the reason for the genetic testing.
And I think there's a case for doing it anyway in that case. And I will revise that. If you were taking this case without the family history, you would not do that based just on age. And people do that on age if you don't really have classic CT features. Yes, I think it is in that case worth doing that. It's worth doing that because if there is a genetic mutation, the disease is more likely to be more aggressive. And that is really what that is telling you. And you would be a bit cautious about overdoing immunosuppression, although you would institute it.
Thank you.
Yeah, so I agree with everything Professor Wells said. A couple of things. One is, I'd like to ask Dr. Mithun if doing a nail fold capillaroscopy will help. Is it something that will pick up fairly early systemic sclerosis in? And it's a nice non-invasive way of trying to look at your diagnosis.
Yes, nail fold capillaroscopy can pick up early changes, especially in our tropical climate. We may not get that typical Raynaud's phenomenon and any loss of capillaries or the dilated giant capillaries all gives a clue. Problem is that not many centers have this nail fold capillaroscopy. Or those who have the nail fold capillaroscopy, they have the low quality nail fold capillaroscopy. Very difficult to see. The original nail fold capillaroscopy is little costly. It's not available in most centers. That's one issue. What we otherwise do is we use a handheld dermatoscope. Those things you can do. But if it is available, it's a very useful test.
So if you don't get an answer from the antibody profile, then I would probably would consider biopsy, but only in that case. And I would probably, given the family history, I'd like to go deeper into the family history. Is there any history of chronic liver disease? Any signs of premature aging in anyone, which would make this genetic testing a little more worthwhile doing. But I would probably do those non-invasive tests before pushing her through a biopsy. And if you do decide on a biopsy, I'd probably go for a cryo. It's much more likely to give you a right answer than a transbronchial, forceps biopsy.
I'd like to comment briefly on the first point to support it extremely strongly. We're building a diagnosis on clues, and another clue would make you that much more secure that you weren't going down the biopsy pathway. And I appreciate the biopsy pathway as a matter of debate. But I do think the patient should know it's a very close call, and that should be part of the decision. The other thing I would do with ulcers in this setting is test more formally for Sjögren's. And I think that you might find if you do the basic Sjögren's test, so perhaps a Schirmer's test, you might end up doing a lip biopsy rather than a lung biopsy in order to establish CTD. It might just be secondary Sjögren's, of course, and you might not get a yield from that pathway, but supporting strongly that you're doing everything you can that is less invasive, I would include that, I think, in the workup. At least explore for sicker symptoms and be ready to have a very low threshold for taking that question further.
Rajan sir, you would like to add something, or we'll move on to the next case?
No, I think we can move on to the next case. Great discussion.
Yeah, Suresh, I hope your questions are answered. Thank you so much for sharing your
Thank
case.
you. Yeah, thank you.
Thank you. I'll move to my cases. Thank you. So
that's the RVTLC you just showed. And while you're loading, I've tended to look at the flow volume curve at that point to see if the flow volume curve ends prematurely and you've got a spurious RV over TLC because you're not completing the FVC. Sorry, go ahead.
Sure. So Aparna, this is Mr. MK for you. Okay. Yeah, so this is a 71 years old man who is from nearby area from my hospital, who presented with he had herpes infection in July 23, which was managed conservatively. He has got dyslipidemia and hypertension for which he is being treated. Presented to me with cough for last 10 months. That is what he's telling. However, family members feels that he is coughing for more than that, maybe 1 or 2 years. Mainly dry cough, but sometimes the phlegm also comes out. He was evaluated at outside hospital for GERD and they found that grade 1 reflux esophagitis for which he was being treated. Now the daughter is a doctor and she brought him here. And his HRCT scan was taken, which was reported as a UIP pattern outside. They came here for second opinion. And CT chest outside will be shown by Aparna in a short while. Before that, I'll just tell what was his clinical examination. He had clubbing, he had bilateral Velcro crepitations, and his saturation on room air was 93% in sitting position. In chest x-ray, there was significant reduction in lung volume. Echo, which was done outside, there was no pulmonary hypertension and no LV dysfunction. His ESR was 32, calcium was 9.4. Other than that, all the profile, including myositis, were negative. ANA profile was negative. ANA as such was negative. His LFT and alkaline phosphatase were normal. This is his spirometry, which was restrictive pattern, and DLCO was 57 with a KCO of 75%. He walked for 420 meters in 6 minutes and desaturated to 91%, but his dyspnea box score was 0. Now I'll stop sharing my slides and Aparna can show the images.
Yeah, I'll just share my screen. So this is the CT and we are seeing a lot of reticulation subpleurally and there is honeycombing which is there in the upper lobes as well, anteriorly, even posteriorly. And as we come down, there's definitely more honeycombing in the lower lobes. So there are again areas of honeycombing that we're seeing. It's a little asymmetrical. Right side looks a little more severely involved, but there is definitely involvement of the left side also. There is some form of mild dilatation of the trachea. I don't know whether it's age related or whether it is related to the fibrosis causing some amount of dilatation. So mild irregularity and dilatation of the trachea is there. Other than this, his pulmonary artery was not dilated. Oh, it's taking some time to load. His pulmonary artery was not dilated, but he had few small nodes. So some small volume nodes like 13, 14 millimeter sized mediastinal, subcarinal and small hilar nodes were there. So I think radiologically it is fitting with the typical UIP pattern because mainly it is the honeycombing that we are seeing, a lot of reticulations and honeycombing. The distribution is a little bit atypical in the form of that significant anterior upper lobe involvement is also there. But overall, I think it is fitting into a UIP pattern. Okay. These are the coronal images.
Asmita, correct me if I'm wrong, the vital capacity was 90% of predicted, you mentioned?
1 second, I don't remember now. 81% is FVC and 95% was FEV1. Is there any emphysema going on there?
Mild, the lung volumes are not much reduced for the amount of fibrosis, but otherwise not really seeing any definite emphysema.
Yeah, the lung capacities were not
Yeah.
decreased in the FE1, FVC wise and otherwise also. Yeah.
Yeah, the volumes are not much reduced, definitely on the CT also. Yeah, but not specifically seeing emphysema like picture.
I would not be too bothered about that because we never know the pre-morbid lung function. The normal range is 80 to 120. And my guess is that this patient, had they had their lung function measured before they ever got the disease, might have been touching 120. So I would not be changing perceptions of the case based on that vital capacity because it's too classical in other ways.
Yeah. So I'll just share my screen once more and will put my questions, which is actually representing her questions. So I because I was worried about his cough and his desaturation, started him on nintedanib, 100 milligram. That was 5 days before. And then this is his workup, which was negative. ESR is high. He has main complaint of cough, and his basic problem was, as Radhan sir pointed out, that it's very well preserved lung function. Do I need to treat? Do I need to continue nintedanib, or should I stop it, or do we need to treat? That is the main doubt, because the family was also concerned that side effect of the drugs, considering his age is 71 and with very well preserved lung function. So my question is, do we need to treat? And second question was, is it classical UIP? Do I need to do anything else? Absolutely, family is not willing for biopsy.
Well, I can say that I would treat Asmita, no question about it.
Okay.
I agree with Athol. We are probably, if you had got this gentleman's lung function done some months ago, or some years ago, he could have been much above 100% of predicted. So looking at that scan, I would not treat. Definitely not. I would start treatment. I'm not sure why he's on UD-Liv though. I don't think that has any role here.
Okay.
And that's ursodeoxycholic acid that doesn't have any indication, but I'd get him onto full dose nintedanib and see how he tolerates it. And
Sure.
I don't think I have anything further to add to this. Probably do an autoimmune serology. The ANA, all that is negative, right?
Everything
That's all
negative. Yeah,
negative.
everything nicely worked up. Myositis also done negative.
Yeah, then that's fine. That's fine.
I want to add one other crucial treatment, just putting this together. This is IPF, and in any case, I believe strongly that UIP that is classic should be viewed as a standalone entity with the same sort of outcomes, whether you have primary UIP or secondary UIP, but this is IPF. I'd say there's one other feature that interests me greatly, and that is the reflux. You've got asymmetry on the scan, you've got cough, and we do believe that reflux may be a key driver of progression in a subset of patients with IPF. I would say a rigorous treatment of reflux, and that includes also the non-pharmacological approaches, because you can stop the acid, but you can't stop the pepsin and the bile salts. So head of bed on or propped up by pillows, main meal earlier in the evening. It might be difficult in India to avoid spiced foods, I suppose, but everything you would do with reflux might be pivotal here in a better treated outcome.
Okay.
You might ask him if he tends to lie on the left when he sleeps at night. There has been documentation that when you have asymmetric IPF, the asymmetry is very commonly on the side on which the patient lies at night.
Wow.
Heraclian et al., it was quite striking. But
I will ask that. I'll ask that.
You've got a lot
I'll
going
ask that.
Yes, haven't you? The esophagus and stomach.
Patient sleeps.
Which side was it worse, Aparna? Between the two sides?
Right side.
Right side.
Right side.
Right side. Yeah, because there was one paper from the Brompton talking about right lung involvement being more in reflux. I remember.
Right.
Yeah, that's what he
One
said.
more point I'd like to add, that is, if we really believe that he started out with a greater than 100%, then he's already fairly far down the road of fibrosis and loss of, lung function. So definitely, if not for any other reason, I believe every IPF should have it up front. It's a good idea to start the nintedanib and push it to its maximum tolerated dose.
Sure.
I think you should rely on DLCO much more than FVC when you're looking at severity of IPF. There's less noise to signal ratio. The noise is the confounding of the normal range, but the DLCO reflects both loss of volume and loss of vascular volume. Sure. And on average, it's much more distant from the normal range. So your DLCO, I think, was 57%.
Yeah.
Was it?
Yes.
And he might have started at 120% DLCO. So I think he's at least 3 out of 5 or 3 to 4 out of 5 in severity if you have a 5-point scale.
Okay, I think that sums up. I will move on to the third case, which is really interesting, and I am very happy that I have put it here. 1 second. This is Mr. MP, Aparna.
Yes, Doctor.
Yeah. So he's a 54-year-old man who works as a supervisor, supervisor of a construction site. And he's not a smoker, not an alcoholic, and is vegetarian. History of extrapulmonary tuberculosis. What he can recall is it was in 2008 and left cervical lymph node was positive. Biopsy was taken, proven as a tuberculosis, and received 6 months of TB medicines. In 2022, he came to our hospital and was visiting gastroenterology department and was started on mesacol for ulcerative colitis, and he had COVID infection as other people have in their life. Now he has other presenting complaint to me was he was yawning too much, so wife brought him here. So like it was unusual yawning. Other than that, he has bouts of cough which can lead to syncope kind of thing. So intermittent episodes of cough with vitis expectoration and grade 2 MMRC for last few years. Other than that, all history of CTD workup was negative, no history of exposure. Since childhood, he has eosinophilia, reported to have increased eosinophil count since childhood. He has significant nasal allergy symptoms, watery secretions from the nose, as well as recurrent throat infection. His father also had asthma. That's what he told. Now, this is very interesting part, which make me think that can it be sarcoidosis? So around 2 months before, he had episode of syncope. Whether we can call it syncope or not is very debatable because he had 5 minutes loss of consciousness and he does not remember what happened meanwhile. He was brought to the hospital. He had involuntary micturition. He had uprolling of eyeballs, but no seizure-like activity, no tongue biting. That time they did ECG, which showed all T waves in lateral leads, repolarization, and then afterwards, within 1 hour, ECG became normal. That time TROP-T was checked, which was normal. He was evaluated for the same by our hospital neurology department prior to coming to me, and that those people did EEG, that was normal. No MRI was taken, but he was reassured that he doesn't have any issue. So this is all the background, and he came to me for cough and yawning. Yawning, I could not do anything about, but his saturation was 98% and BP was normal. I did his workup for ANS screening, which was 1+. RF factor was positive, but it is 10, and by now I think Mithun also will agree it was not significant. I didn't do anti-CCP because he had financial problem, but other investigations were normal. We have done his I didn't do myositis panel also because of the same reason. This is his spirometry. FEV1 was 64% and FVC was 59%. DLCO was 63%. DLCO by VO I forgot to write, but I will let you know. 6-minute walk test was 97 to 94%, and he desaturated 3% with 360 meters he covered. Now I think I will stop sharing, and the reason I did PET CT, that particular moment, my first diagnosis was sarcoidosis, and I was thinking that all the symptoms are relating, and that is why I did PET CT.
Shall I show the CT?
Yes, go ahead.
Okay. First, I'll just show the HRCT and then I'll quickly show the PET. So on the HRCT, what we're seeing is predominantly peripheral kind of opacities, which are partly consolidations and some areas of fibrosis also, as we can see, focal cystic air spaces and mild traction bronchiectasis. It's there in the upper lobes as well as lower lobes. Adjacent pleura is also showing some mild thickening. So that is the main finding that we're seeing on the HRCT. And then this is the contrast CT part of the PET CT. So since you're talking mainly about sarcoid, I'm looking for nodes also. So there are some very small nodes, but no significant lymphadenopathy is there. In the abdomen also he has some findings. So his right branch of portal vein is kind of thrombosed, like a chronic thrombosis, and it is replaced by like a portal cavernoma. A lot of collaterals are there. So that is one main finding in the abdomen. You told about ulcerative colitis. So colon is not really looking much abnormal on this CT. Now coming to the PET images. So there is some uptake in the parotid glands, but that can be normal. The submandibular glands are also showing some FDG uptake. So since this FDG can be secreted by saliva, that can be normal, and sublingual also. So all this can be a normal uptake. Again, since we are looking for any lymph node uptake, there's no lymph node uptake in the thorax. Some of these peripheral opacities are showing some minimal uptake, I think, but we will have to actually check whether that is anything significant. Other than that, we are not really, even in the colon also, we are not really seeing any uptake. No lymphadenopathy in the abdomen also. So overall, what we're seeing is mainly this peripheral kind of small patchy consolidations. So what are all the things that we can think? You told about eosinophilia. So eosinophilic pneumonia is one thing. Organizing pneumonia, since he is on many drugs that you said, so whether any drug-induced OP, that is the second thing I'm thinking. Third thing, vasculitis also we should consider, because he has this some kind of venous thrombosis. He's having some ulcerative colitis or whatever inflammatory disease, plus predominantly peripheral kind of consolidations. Yeah, so these are the thoughts that I have.
Actually, I think I showed in my slides. I also suspected that vasculitis and MPO-PR3 was done, which is negative. Even though I didn't do myositis, I did MPO-PR3, which was negative. And usually in PET CT, don't you think, Aparna, if it was a major vessel vasculitis, there will be some blood vessel, like if we are not dealing with
No,
very
not
small vessel vasculitis.
no, not a large vessel vasculitis. Large vessels are fine only,
Yeah.
but because that some old venous thrombosis was there, that's why I just brought up this vasculitis also.
Sure.
Yeah.
Definitely. I think you told me about eosinophilic, you told organizing pneumonia, and the third possibility of vasculitis. This does not look like sarcoid, right?
No, nothing
Yeah.
is like sarcoid.
Sure. You can stop sharing. So, yeah, so she rightly pointed out that it was not looking like sarcoid anyway. The diffuse involvement of parotid gland, which is also common in sarcoidosis, and it was homogeneously enhanced. So I actually went ahead and did a biopsy of parotid. And Ritu madam, if you can just say what you are seeing.
Yeah, hi. So what we are seeing here are acini of the parotid, which are mucin-filled normal acini. And there are no granulomas and there is no inflammation which can be seen. So I would put this down into within normal limits, and I would request for a repeat biopsy.
Yeah, so that is what our pathologist also said, and I had discussion with my surgeon, and as we both discussed that there was homogeneous enhancement of parotid, and if we have taken biopsy from anywhere, the pathology, if present, would have come. So we decided against for repeat biopsy of parotid at least, and the reason I put this particular case for discussion was, do we need to do biopsy? Now coming back to the medicines again. So Misacol 1.2, and today the patient came for review, and I had almost 1 hour conversation with him, and I was able to find out this thing which I have not shared with Aparna because I got it today only. So what has happened is 2021 X-ray was normal. The diagnosis of ulcerative colitis happened in 2022 by colon biopsy, like colonoscopy biopsy. And he was started on Mesacol for almost 19 months. I found out that March 23 was the biopsy proven ulcerative colitis, and he was initiated on Mesacol 1.2 gram twice daily. And this is his X-ray. So now the question is, now I also agree that sarcoidosis will not fit. But these are my questions. That is it sarcoidosis? That is out of question, that it is not. What was the neurological problem, which I also don't know. Parotid gland, should we repeat biopsy? Then is there a need for EBUS or cryobiopsy, or is it Now I have put a drug-induced ILD because I did some research and I found out surprisingly that mesacol or mesalazine is known to cause ILD. So I have not seen mesalazine induced ILD because mesacol is such a benign drug many people will be taking. So I definitely I don't know whether I'm on the right track.
Ma'am, can I answer one thing about the
Yeah.
parotid? I
Yeah.
don't think you need to biopsy it because
Sure.
uptake of on the parotid is normal. Definitely,
Sure,
you
sure.
don't need. And
Definitely.
I also quickly looked the toxicity of mesocol. It can fit into
It
this
can,
OP-like
it can.
pattern. Yes.
Definitely. And second thing is, if it is drug-induced ILD, then also eosinophil will be high. And his eosinophil, I checked again, it has never gone below 4%, but never gone above 7% also. So to call it as eosinophilic, this thing will also be difficult. But I have not seen mesalazine-induced ILD, not necessary. People would have seen. So please.
He was on half the dose of mesalazine, right, Asmita?
1.2 gram twice
Yeah.
daily.
Twice daily.
For
That's
twice daily
the
for
full,
19 months. 19 months
the
almost.
full dose is 2.4 twice daily, right? So
No,
that's
it is around 1 to 2 grams, sir. I checked it. So the
okay.
total dose 1 to 2 grams. So he's almost as per his weight.
All right. I missed a bit, so I defer to Murli and Athol. I got caught up in some WASOG related calls
Sure.
during this case, so I'd leave it to Athol and Murli to comment.
I come at this with two hypotheses. Now, this is one of those situations where you have potentially multiple triggers. I'm only going to say briefly about post-COVID, is that we know that if there's an element of long COVID, you do have immune hyperreactivity, but I would tend to see that if there is long COVID at amplifying one of the two hypotheses. I'll go with my favored one first. The scan shows OP-NSIP, and I think if you look closely at the scan, there are areas of ground glass with traction. So this is OP-NSIP, I think. I don't like eosinophilic pneumonia. The peripheral consolidation tends to be more acute with asthma, and I don't think I've heard there's an eosinophilia. Of course, you can have just a large eosinophilia. It just does not feel right. So I think there are two hypotheses. The first is two things. I note the DLCO is higher than the FVC, and I would instantly be suspicious of respiratory muscle weakness. I don't think the cardiac events, I don't think you can dismiss them as a coincidence. And anything that can happen with sarcoid in the heart can happen with inflammatory myopathy. The problem with the PET is that that only works if you've got current active inflammation, and knowing there's diastolic dysfunction, I would get a CMR, an MRI scan of the heart, and be looking for the sort of signal that you might see in one of those inflammatory myopathy processes that might not be giving you much muscle signal, but giving you more of a lung signal. I think the OP-NSIP would do nicely for that. I think the age of the patient would do nicely for that. And it would be perilous, I think, to assume you've got cardiac abnormalities that haven't been explained, and it is more satisfactory to bring them into that hypothesis. The second one clearly is that you are simply getting a reaction to mesalazine. I do think that sometimes it's multiple triggers or processes for a single outcome. It doesn't have to be mesalazine or an occult inflammatory myopathy. It can be a combo of the two things. So before you even think about biopsy, I would do two things: a myositis screen and an MRI scan of the heart. Now, I don't think you'll get anything other than OP-NSIP on a biopsy. I think we're like the first case that we could debate at length whether a biopsy will do anything in the way of treatment or will shift the diagnosis. I think myself that it's unlikely that it will in this particular case.
Yeah.
But sometimes, if you are uncertain, the advantage of a biopsy is that you have gone as far as you can and you're not left with the feeling, sometimes by doctors outside an expert centre, without a biopsy, they feel insecure, and that is bad for management. So those are my two hypotheses. I do think a myositis screen here is pivotal, and that's all I can really think to say, except to highlight again that a DLCO of 63 and an FVC of 59 is telling you that there almost certainly has to be an extrapulmonic restriction.
Okay, Murli sir.
Yeah, so agree completely on all that. But I think you should also bring in the possibility that the ulcerative colitis itself is causing the problem. Because I've had patients with ulcerative colitis who present with an organizing pneumonia. In fact, I was hoping to show it the next time, where we have a biopsy-proven OP in a patient with organizing pneumonia. And the rest of it is, as Professor Wells said,
No. Whether the patient was on mesalazine.
the patient was on mesalazine and had ulcerative colitis, and there are patients who've had ulcerative colitis who are not on mesalazine and who have organizing pneumonia also.
Okay.
So whether it's the drug or the disease is virtually impossible to say.
Okay.
The other point is we've not explained his yawning, which brought him to your attention first.
Yeah. I don't know. Yeah,
So
he kept
wondering
on
if
yawning.
you need
Yeah.
to check his saturation supine and sitting as a very simple bedside test, see if there's any drop, which will explain his, which will be explained by his muscle weakness, and then consider doing an overnight oximetry at least. I'm not sure why he's yawning so much.
Mm-hmm.
He could have respiratory muscle weakness, and that might be contributing to desaturation at night, I suppose. And yeah, I think it's a neat further option. As you say, you've probably got to lump together mesalazine and ulcerative colitis. And one thing you do, whatever else, is to stop the mesalazine.
Yeah. Yeah, that itself can cure it. That's what some of the reports have said, and I believe that answers.
Can you do his MIPS and MEPS, Dr. Asmita?
I can try. Let me see here. Yeah.
But certainly a myositis profile, I think, is very high on the OP and SIP. I think it's automatic. You've got to do it.
Yeah, we'll do that. I'll do that. I will go to last case. Today we are fast, isn't it? We are just moving so fast that we reached case 4.
I'll request our resident Dr. Gautam to present the case. Gautam, can you unmute and come on?
Sure, sir. Good evening, everyone. So this is Mr. X, a 36-year-old male, an IT professional from Bangalore, came with complaints of dry cough and functional class 2 breathlessness since 2 months. No history of nocturnal cough, wheeze, chest pain, giddiness, palpitations, syncope, nothing to point towards cardiac. No history suggestive of connective tissue disease, no history of weight loss, no pet exposure, and he's an occasional smoker who smokes almost 1 or 2 cigarettes in 6 months or 1 year. That's it. Next slide, please. So history of recurrent boils in childhood, history of fever, abdomen pain and dyspepsia in 2013, for which colonoscopy was done, suggestive of ulcers. According to patients, according to the patient, but no details available. History of pilonidal sinus 5 months back, for which surgery was being done. And history of hydradenitis suppurativa in bilateral axilla, left more than right, during 2023, which lasted for 7 months. And surgery was also done for the hydradenitis suppurativa. No family history of asthma, autoimmune disease, or malignancy. On examination, is conscious oriented afebrile, no pylorictus, cyanosis, clubbing, or lymphadenopathy, no pedal edema or elevated JVP. Bilateral basal Krebs were there, and SpO2 98% maintaining on room air. So initially consulted a cardiologist for this breathlessness and cough. TMT in 2-day course and reported normal. So subsequently did a CT thorax, which is suggestive of ILD. We have given the CT, we have mailed the CT. Then evaluated in Manipal Hospital for ILD, for which ANA profile, ANCA, rheumatoid factor, anti-CCP all were negative. In myositis profile, anti-OJ1 was borderline 1+. So ACE levels of 54 and CPK calcium levels were normal. Serology was non-reactive. PFT suggests a restrictive pattern, and DLCO is reduced with 47% predicted and KCO of 137% predicted. Next slide, please. So he subsequently underwent a VATS-guided VATS-assisted lung biopsy on 10th of last month. So HPE, the report is as follows. The lung biopsy shows advanced microscopic honeycomb remodeling. Normal lung tissue is only focal identified with an occasional fibroblastic focus. The HRCT findings of basal predominance pathology and HPE features of architectural distortion and spatial and temporal variations of fibrosis, albeit focal, are in keeping with UAP pattern of lung injury. The presence of a significant interstitial lymphoplasmocytic infiltrate in the interstitium raises the possibility of underlying connective tissue disorder and enterological factor. So he's currently on MMF 500 mg once a day and Nintedanib 100 mg BD since 3 weeks. So we have discussed in ILD meet and we have repeatedly CT thorax and whole exome sequencing also been sent. The CT thorax also we have mailed.
Yeah.
I'm sorry, we don't have the histopathology slides. He came yesterday, he's promised to bring them back. We only have the report.
Sure. Yeah, Aparna, go ahead.
Yeah, these are the CTs. There are two CTs. One is from August and this is from October, so 2 months apart. The August one, for some reason, has only few images, only the lower lobe kind of images are there. But whatever the things that are comparable are looking quite similar. So the October one, we have the full CT. So I'll start from the upper lobes. So there is some minimal subpleural involvement in the upper lobes with the minimal reticulations and adjacent pleural thickening, and more severe involvement of the lower lobes where the predominant thing is ground glass opacities, little bit of reticulations and mild traction bronchiectasis. There is no significant honeycombing. If we see the coronal, so we are seeing some kind of like almost like the straight edge sign that is described in the CTD ILDs. It is having a very sharply demarcated straight kind of edge between the abnormal and normal lung. Again, lung volumes are fairly okay. So basically, the predominant finding is the ground glass opacities, and it is having some kind of apicobasal gradient. So I would think young age plus everything put together like a CTD ILD, NSIP pattern or NSIP OP overlap type of pattern.
Okay.
So our questions I have mentioned in my slides.
Yeah, one second.
I think the UIP in the pathology is not correlating with the NSIP on the radiology, right? That is one main thing.
Yes, yes. So is this an ILD? If yes, what pattern of ILD? Does borderline OJ1 plus carry any clinical significance in this setting? Does clinical, radiological, and histopathological findings match? Do we treat it as UAP or CTD ILD? And how do you proceed with immunomodulation currently? Thank you.
Who would you like to comment on this one?
Yeah, I think this is definitely an ILD. I wouldn't. I would probably say this is a form of connective tissue disease, ILD. The anti-OJ borderline 1+, I would leave it to Mithun to comment on. But the clinical, radiological, and histopathological findings do match largely. I would immunomodulate. I would hesitate in giving antifibrotics at this stage. Those are my answers, Asmita.
Yeah. Murli sir, we will give Atharval sir last this time.
No, this is our patient. Actually, he's not my patient. He's my colleague, Dr. Ranganath's patient. But we have discussed it at the first CT at the ILD meet, and we were not very happy with the quality. So we did the second one, though it's just 2 to 3 months. The patient himself is very well preserved and has absolutely no symptoms to suggest a CTD, which is why our problem. I think I'm fairly convinced we are dealing with an ILD, and I completely agree with Dr. Aparna that we're probably dealing with a CTD ILD. Beyond that, the relevance of the OJ1, I think.
Mithun, I think you are itching to talk. You please talk.
If you want to diagnose based only on some antibodies, it should be fairly strongly positive. just by borderline positive. If patient has other features of myositis, then it's okay. Otherwise, it's difficult to say that it is significant. That's
Yeah.
all.
Yeah, agreed.
Yeah, and to my mind, the histopathology was not really convincing. I was, a couple of fibroblastic foci in the rest of it, a lot of inflammatory cells there. I would much rather call it a CTD-ILD than a classic type EFUIP. So, Professor Wells, yours.
The only other thing before Athol starts is the boils, if I may, and the hidradenitis suppurae. I was just reading a little about that, and that's genetic 1/3 the time, and so I know that whole exome sequencing was sent out. So I think you are thinking of some genetic immunological condition coexisting with this, and I can't think of anything offhand, unless Athol has more thoughts.
Hidradenitis suppurativa, IBD, or they are associated.
Okay.
They can happen together.
So there is an autoimmune, it is basically an autoimmune process, not this infection that we used to think it was earlier.
Sure.
But I looked for lung involvement, and there's hardly any description of lung involvement in this condition. There are a couple of reports, but not an ILD. So we're still in a bit.
Right.
This is a very strange case, and I think to deconstruct it, I'd like to go back to the slides. I'm going to amplify your point, Sujit, but I'd like to go back to the first slide. Yes, next slide. This history shouts infection, and I think that I'm going to speak to something that isn't properly stated in texts. So I'm immediately suspicious of some form of immunodeficiency in the background. And the problem is, if you don't identify these forms of immunodeficiency, they don't fit classic tests. You don't diagnose them. And what I've seen on multiple occasions, and Sujit, an example is a case we discussed of yours.
Yes.
But you get these pathways where there's impairment of your focused immune responses, but infective antigens aren't cleared easily, and they're still there, and destructive secondary innate immunity pathways that are not so focused are overexpressed, and they drive weird lung disease. So I'd go further. The immune genome is what you want to access, and if you haven't done all of the tests you would routinely do for immunodeficiency, I wouldn't assume that this history, because it is so striking, is irrelevant to what's occurred. Now, next, and I say this is a strange case, and next, lung function is what I want. Now, lung function, go back. Let's break this down a little. So this is a patient. I don't know what the % predicted FVC is, and I do want to know that, because what I see is a DLCO of 47% and a KCO of 137%. And I don't really understand that, because that is really shouting that there's significant extrapulmonic restriction. Now, I think that if the FVC is, say, at, I don't know, 55, 40%, that's telling me that the KCO is telling you there's extrapulmonic restriction. But I think what you do, of course, is check that the patient was properly instructed and understood instructions when they performed the gas transfer. So I leave that as an asterisk. I'm not saying that I know there's extrapulmonic restriction, but it hits me fairly and squarely in the eyes when I look at that lung function. Now we go down to the scan, and you've got UIP, but what you've not got is UIP in the scan. I think that we don't need to show the scan again, but I would have said the distribution was very interesting. I don't think I can quite call it bronchocentric, but it's a whole lot more bronchocentric, because it's a bit random, isn't it? But there are areas, especially in the lower lobes, where this seems to reach out from the central airways and go through to the pleura. So immediately, I think this is a terribly difficult disease to classify. And I think the lymphoplasmocytic infiltrate, that could be about CTD, but it could also be about weird responses in immunodeficiency. I'm not saying I can say this is an immunodeficiency-driven process, but we have to think about that because you're talking about immunosuppression as your first line of attack. So when I take all of this and you're asking how you could mess it up, I think one pathway to doing that is that this is really being driven, much as GLILD is driven, for example, much as LIP and HIV is driven, much as isolated populations around the world get devastating bronchiectasis when they're colonized. They don't have good primary immune reactions to widespread infective antigen. My instinct here is that something like this might be going on, and best management might still be immunomodulation. We use it for GLILD in common variable immunodeficiency, but we use it also by dealing at the same time with an underlying immune deficiency. And I think that this is weird. I strongly support your genetic exploration, but you also want to make sure that you're covering both the immune genome and the ILD genome in whatever you're examining. And that is all I can say about this. I think it's unclassifiable. It might be that there's a label of CTD-ILD, but distrusting coincidence as I do, and taking aboard the striking infection history, I don't think you should go straight to managing in isolation as CTD-ILD. And whatever else, if there's a smidgen of immune deficiency, you've got to think very carefully as to what else you give when you actually use immunosuppressive therapy.
Great, thank you. It's interesting. I haven't seen this patient, but I just popped into my colleague's room to discuss something else and saw him there. Picture of good health. He's rather obese, which may explain why he has some extra pulmonary restriction. So I probably misuse the term good health, but in India, the term in North India is healthy when a person is rather obese. So that's one. The second interesting point is our radiologist was doubtful that this was an ILD based on the first CT and said, I'm thinking of recurrent infection. So that's very interesting, Professor Wells, what you said, that infection may underlie this whole thing. So we look at his immune deficiency. I don't think we've done it yet.
I was very pleased to hear about the obesity, firstly, because I was once a lot more obese personally, but secondly, I did not want to say muscle weakness because I don't really trust the CTD-ILD designation. And the moment you say muscle weakness, respiratory muscle weakness, you're marching towards that conclusion. And I wasn't sure I believed it. So the obesity is a good explanation as to why the KCO might be as high as it is. So that's important. These are very tricky because you can feel instinctively there's immune deficiency. You can do every test under the sun, but you're not testing deficiency to specific antigens. We have the bullseye where you have a more generic immunodeficiency. And I still think even if you don't get the formal immunodeficiency signal, you certainly need some sort of antibiotic cover that is fairly rigorous if you do use immunosuppression. Nor do I think if it's an immune deficiency that if you've identified and covered for it, that it's out of court to use cautious immunosuppression, as we do in GLILD and CVID. And I suspect it's got to be that sort of combination approach. And even if I found out I was wrong later on, I would want to still have covered the possibility.
Great, thank you so much. Dr. Asminta, you're muted.
We have got Dr. Alpa Dalal's case for reconsultation. Can I just share the slides which she presented last time for a sake of Professor Wells, who was not there?
Well, you can do it really fast.
Yeah, I will do that. Yeah. So this was a 44-year-old lady. This is the case, right, madam? Alpa, madam, can you present?
Yes, ma'am. Ma'am, actually, I am her student. Alpa ma'am is in a meeting, so I'll be representing on her behalf.
Yeah, you have 2
Uh,
minutes to scroll through the
Okay.
slides. Yeah.
Okay, ma'am. Yes, ma'am. So this case was discussed in the last MDM. 44-year-old lady, married homemaker. She first presented in April 2021 with dyspnea grade 2 MMRC since the last 2 years, that is since 2019, and chest pain and intermittent chest heaviness since 2019. Her CT scan done at that time was suggestive of sarcoidosis. ACE levels and CTD workup was negative, and she showed a good clinical response with steroids. So from 2021 till December 2023, she was on azathioprine 100 milligrams per day, prednisolone 5 milligrams per day, and an inhaler for Accord 200 microgram once a day. Later, she lost to follow-up, and she revisited us in December 2023 with the similar complaints of palpitations and chest pain and dyspnea grade 2 MMRC. At that time, she was on the same medication of azathioprine and prednisolone. Serial PFTs were done, which showed a drop in her lung functions, and then she was changed on methotrexate 15 milligrams per week, and the steroid dose was continued to prednisolone 5 milligrams per day. So, whenever we tried tapering her steroid dose, the chest pain and heaviness started increasing. These are her serial PFTs from December 2021 to September 2024, which is showing some decline in FVC around 200 ml, and the DLCO also. Ma'am, next slide.
1 second. Let us just
Oh,
everybody have a gauge of it.
okay, ma'am. Okay, ma'am.
So you changed to gas transfer units part of the way through. So that all makes sense. Keep going.
Yeah.
Okay. Okay. And this was her 6-minute walk test that was done. So, So the questions that were asked last time were, should we go ahead with a bronchoscopy and a TBLV? What are the further treatment options, whether to restart steroids and whether to start her on antifibrotics, and what are the long-term prognosis. So the panel agreed on getting her PET scan done. So we have done her PET scan, which is not showing any significant lymphadenopathy. The right paratracheal node is around 1.4 into 1 centimeter, which is showing a SUV of 3.42. Rest, there is no other lymphadenopathy. So, should we still go ahead with the biopsy for the confirmation? That was our question.
I think this was the same patient whom, as you tapered the
Yeah.
steroid to a very low dose, the lung function dropped. Am I right?
Yes, sir. Yes, sir. We had referred her to you.
So can you get the lung functions back on the slides?
Yeah, I will
Okay,
do
sir.
that. I'll do that.
So Murli and Athol, this was recently, I think in May 2024, the prednisolone went down to 2.5 milligrams a day or alternate day, was it?
Uh, yes, sir. 2.5 milligrams per day. And then
Right.
she started having,
Then she was worse. So the
yes,
easiest
sir,
thing to do
worse.
for her was get her back on steroid or increase the dose. But she's a young lady. And we've never had a biopsy on her. The imaging, could we see the imaging? Is it possible? Because otherwise they won't have context on the follow-up.
Yeah, we don't have images because images were with Bhavin sir and I didn't save it.
And
Yeah.
Athol won't be able to comment, no, us without.
Yeah.
We can.
Comment on the words used, actually.
Right. There was a very strong suspicion on the imaging of chronic sarcoid here.
Mm.
That was the
Mhm.
suspicion, I remember. And so the easiest thing would be bump up the steroid, add methotrexate, is what we were thinking along, if I recollect, Alpa's thought was there. And then we said, shouldn't we biopsy because this girl is young, and if we're considering monoclonal antibodies, we should have pathology, which we didn't have. And that's where the discussion ended, and this lady was very keen to get off steroid.
Okay, well, the first thing is that you biopsy in areas that you might have a yield. And I was struck that the PET scan showed signal in a lymph node, but you didn't say it showed signal in the lungs. And the PET scan's been done after you've reintroduced steroid. And rather than doing a lung biopsy, I think you go straight to EBUS and you do a BAL as well. And I'm not sure what you do if that's negative. It's something you think about at the time. And obviously not seeing how likely sarcoid is on the scan, I suspect it might be one of those that you can't come up with a plausible differential. And so I do the EBUS for sure. That's where the PET signal is. I think if this is sarcoid, you're likely to have a high yield, and then you know where you are. Management, I think it's essential to minimize steroid. And what was the dose of methotrexate?
It hasn't been started. No,
Methotrexate once in a week.
once in a
Yeah,
once.
once in a week, sir.
How
So
many?
15 milligrams per week,
It's done.
7.5 milligrams on Saturday, Sunday.
First of all, 15 milligrams per week may not be adequate. And I
Okay.
think be pushing up to a higher dose. I can't stress too strongly how strongly I think we should be shifting the emphasis away from steroid and sarcoidosis. And there's a leadership group in sarcoid that is likely to make a strong statement about this. So I'm not saying stop steroid at all. And in her case, I think you go with more steroid than you're comfortable with, purely because the fall happened when you reduced steroid. But I would be psyching up the alternative therapies with a view to minimizing steroid as rapidly as possible. So I would certainly want to, the unfortunate thing, and it's nobody's fault, but the PET scan was done after you reintroduced the steroid, I think. And so I think it would have been uneasy while she was declining if you didn't have PET signal in the lungs. But I'm not so sure that it's so uneasy. But the plus is that on what you've done, I see the FVC stabilizing, and I hear about no PET signal in the lungs. So you've got a level of treatment that probably is equal to dealing with an inflammatory fibrotic pathway. And you then work towards finding ways to get an equivalent effect with less steroid and more alternative agents. And in doing so, you also fit with what she wants. And so I would seriously consider confirm sarcoid and think about anti-TNF therapy. Combination with methotrexate is a good idea. And maybe if you settle on that, you don't actually up the methotrexate, you introduce the anti-TNF with the current dose of methotrexate. You establish stability over a slightly longer period, and then you tiptoe down the dose of steroid.
So two things, Athol. One is, I think the PET scan, correct me if I'm wrong, Alpa's postgraduate.
Yes, sir.
The
Yes, sir.
prednisolone was at 2.5 a day when the PET CT was done, right?
No, sir, 5 milligrams per day.
Oh, you're
Whenever we used to, yes, sir.
yeah, which is a
She
very
was on 5 milligrams per day. Yes.
she's been on prednisolone all along, and so fairly low dose, I thought, Athol.
Okay, I have one more thought then. And in sarcoid, you have this minority subset that develop epithelial fibrotic pathways. I'd be scrutinizing the scan for anything. It doesn't have to be classic UIP, but any element on the scan with the phenotype in sarcoid that is honeycombing stroke UIP-like. And if there's evolution on the scan towards that, I would definitely introduce an antifibrotic drug.
Right. And what is the maximum dose you would go to with methotrexate, Athol? Would it be 25 mg a week?
It tends to be 25. I think it's worth mentioning that neurologists dealing with neurosarcoid go to that very routinely. We're uncomfortable because we're not used to that in our specialty, but I've used it in cardiac sarcoid for the last decade.
Sure.
I don't think on average you get into too much trouble. It's just it's outside our comfort zone.
Sure.
I think
But
that's it.
what is interesting is this sort of fall with small steroid reductions when you're not getting a reversal of this, but you haven't really increased the steroid very much. Actually, one thing I would suggest in that case, it's paradoxically you get lower dose steroid in the long term if you actually establish whether you can shift up the lung function with a shorter, sharp burst of steroid. And I think your FVC is down to 47, it was 58. It coincided with reducing the steroid. I think it's worth going for a short approach where you find out if you can rescue some of the lung function. Now, it might be the CT scan, we're not seeing it, we're slightly shadow boxing. It might be you look at the scan and say it's completely implausible that there might be reversibility. And I am bothered by the PET scan if it really showed no signal in the lungs at all. And that's what's driven me towards epithelial fibrotic pathways, a UIP-like underlying pathway. We do in sarcoid every now and then see these patients that have stable sarcoid, and then they develop what is to all intents and purposes IPF. They're a minority, they peep through in the literature, but I've got quite a number of these. And I think we have to keep in mind that what we call IPF, there's epidemiological data that often there's damage 10 or 20 years earlier with coal dust, wood dust, industrial dusts. And it might be that nasty sarcoid with a lot of airway intensity equates with a sort of epidemiological challenge and is a risk factor for evolution to UIP. Be that as it may, I think your question is whether you should add a management that would cover an IPF-like pathway. But again, not looking at the scan, I might be talking rubbish.
No, I think I don't recollect her scan looking like a UIP-like pattern at all.
No, it was showing bleeding. It was classical sarcoidosis. It was that is why the biopsy was not taken.
I'm a little surprised with the PET findings also, that there was no uptake in the lung.
Yeah, it was like galaxy sign, everything was present, and that is why in the first place biopsy was not taken. And we discussed that if we want to take biopsy, better to do PET CT and identify extrapulmonary sites if at all it is present, and to identify the area from where we can do biopsy. And that was.
I think Asmita, I thought we'll be there next time's MDD. So why don't we pull up the images at that time?
Because the images are not there with me, because it was Bhavin sir's direct.
We could ask Bhavin.
It never came across me. Otherwise, I would have saved the images most of the times. But anyway, I have Dr. Amila.
All of us were unanimous that I believe all of us were unanimous that it was sarcoid.
Sarcoid, yeah. There was no diagnostic dilemma, peribronchovascular, fissural nodularity, everything was there. It was classical sarcoidosis. Only thing is, if we are starting anti-TNF alpha, people suggested that better to do biopsy prior to doing that. And as sir rightly said, BAL also can be taken. So it was not a diagnostic dilemma. It was about confirming the diagnosis before starting highest level of immunosuppression. That is what it was. You wanted to discuss your case or not now, sir?
No, not today. Not today.
Yeah, not today. So I think that's it then. And thank you so much for all the people who have joined over that side, and tech support if we can make it on offline for us. Manish. Yeah, sure. So thank you so much, Professor Wells.